Our next speaker is Dr. Tan Wu. He's an orthopedic spine surgeon at Mount Elizabeth Hospital, Singapore. He's the clinical lead of endoscopic spine surgery focus group in Singapore Spine Society, board member of the Asian Missed Education Subcommittee member in APSS. He's going to give us a talk on thoracic endoscopy.
Thank you everyone. Thanks for staying late today in Hong Kong on the Father's Day. Happy Father's Day for everyone. It's my conflict of interest. Currently practicing in Singapore, private practice. I'm also a visiting consultant of 3 government hospitals. I actually do both uniportal and biportal. So for today's topic, I focus mainly on uniportal. There's the evolution of endoscopic spine surgery, as Prof. Song rightly highlighted. I think as we go to more complex surgeries such as thoracic surgery, that's when we really see the true benefit of endoscopic surgery. We can do without chest drain, we can remove this as a day procedure in the thoracic spine. And in some or even spondylodiscitis, you can get the patient moving the very next day. So the scope approaches to spine is a water-based rather than laparoscopic based, which is an air-based procedure, that's thoracoscopy, which we do it for tethers and screws. I think for endoscopy, where we do decompression, we can do it underwater-based procedure. So we have a transforaminal interlaminar approach for uniportal. Arguably, there's also a stereolateral approach if you want to have a more extensive decompression. In biportal, we similarly have an interlaminar paraspinal approaches. We only have 10 minutes, so today we focus on transforaminal, and we have time interlaminar. So in transforaminal thoracic surgery for endoscopy in uniportal, we use small diameter endoscope. I think the challenge compared to lumbar is that we even have a narrower window for putting in our endoscope. We put it actually, dock it in the mid-pedicle line between the rib head as well as that of the pedicle. So if we do have a fluoroscopic view, then we have to do it in the oblique, lateral and AP view to properly dock at the correct area. Usually it's about 4 to 7 cm. I encourage us to actually look at the pathology and see how lateral it is. And this you can actually see the details of how we dock it in one of my articles published. So essentially, let's say we have this prolapse, this T11, this is the docking. Overall, you realize that it's, the pedicle of thoracic spine is rather small, so you dock it in more mid to lateral pedicle line. I don't have an oblique view, but in the oblique view, you should be between the rib head as well as the pedicle. And then we'll dock at the mid pedicle line, and then we move mobile outside in technique. So this transforaminal endoscopic thoracic, this decompression. Actually, when you dock in the endoscope correctly, it's very similar to lumbar. Only 2 caveats. One of them is that there's a lot of bony drilling. So first, we actually may encounter either the rib head or the TP. You may have to drill through it. Depending on the anatomical space. In the T11, 12, I think it's still a wider window, and then in the upper level, in the mid-thoracic level, there's a more narrower window. Fortunately, most of the disc is actually in the T10 to T12 region. So you realize the majority of the surgery is done under drilling. Just to, in our personal experience, me and my mentor, we did a number of cases. We realized that actually if you drill a lot more facets in thoracic spine, they're rather stable. But of course that we have to be prudent about it, but instead of incomplete decompression or docking it blindly into the, not say blindly, fluoroscopic guided, I encourage you to do a little bit more drilling to visualize the spinal cord to prevent any cord injury. So as you can see that we drill do a quite generous foraminoplasty, and then you can actually see the spinal cord, and this is the probably the good way to find where is the disc and remove the disc fragment. So you can see the nodule. It's not big, most of the time it's not big, so it can be removed. But I find that there are a lot of calcified cases as well. In those calcified cases, I find they are also not as calcified as lumbar, so using the ligament cutter usually do the trick. So you can decompress the spine this way. How about in some more challenging cases? If we do have spondylodiscitis like this case, then we are going to, they have some instability on top of just prolapse this. Then we are going to use navigation. Why not we navigate and dock the spondylodiscitis? Maybe that would be an easier trick. Hope they can play this video. Okay, good. So this patient is quite sick, ESRF, diabetes, spondylodiscitis, lots of back pain, also have some weakness in the bilateral lower limb power 4. So the decision made was to do both the spondylodiscitis decompression as well as biopsy and instrumentation. So we can do it under navigation. This video is very similar to how we do a discectomy. I think probably for the interest of time, we'll go more to the next part, which is how we dock under the navigation. So under the navigation, we can actually be quite precise in where we dock. So we use the magic wand to make a small incision and then put the magic wand in. And then we can use when we use the guide to put in the helical guide wire. We can use that to as a navigated probe to put in the guide wire. And after that, then the procedure is very similar. So now we talk about in the uniportal, we also can decompress ossified yellow ligament by doing ULBD. So I think the challenges in thoracic decompression, as we highlighted, is close relationship to pleura, difficulty in identifying. I think the most challenging in some of these cases actually identifying thoracic level, so do take time to do that. And there's actually very little interlaminar window in thoracic spine. You're drilling mostly on the lamina. And calcified OLF also just suggests that there is not the interlaminar space are calcified. For example, this kind of case, I think under the subtle classification, if there are fields and there's more challenging, there's a higher risk of dura tear. But in this type of scenario where there is a cleft, actually it's quite ideal case for for thoracic endoscopic decompression. So I just go, since a video discussion, I go through the surgical technique. I still put them a lot of time on the Wilson frame, and then we have described that this is more of a lumbar paper, but this the thoracic paper that we have published is online. Let's see whether this video play. Okay, good. So this patient has thoracic OLF compression. In this video, play? How come play halfway and stop? Okay. This play, right? Is it a long video? Okay. So we docked the facet joint. I actually docked at the interlaminar space, and then you basically drill the capillary position. Oh, wait, stop and start, huh? Unfortunately, okay. Anyway, so we do a capillary laminotomy, and in OLF you will see basically a calcified yellow ligament. When I do biportal, I drill it very thin. As far as uniportal, you have to drill the OLF thin as well to prevent dura tear actually. Once you drill to the capillary aspect, when the ligamentum flavum is drop off, then you know where is the upper margin. For the lateral margin, it's basically drilling along the lamina on the facet joints. I use a 3.5 mm burr. We need to use very fine, slim sleeve burr. That's why I encourage this is an NSK burr, but there are other slim head burr. But if we use a very thick shaft sleeve that holds on to the burr, we really can't see much on the thoracic spine. It can be dangerous, so use a slim sleeve burr would be good. Let's just keep going forward. So now you see the cleft. In those who have subtle classification E, where they are fused together and the cleft is not present, then it's challenging. So then the next identifying level is the opposite pedicle. You may use the fluoroscopy to help you with that. So then we drill to the contralateral side. Essentially, it will be a block of ossified ligamentum flavum like this. And then you thin it out, and then you thin out the top and the bottom, and then use a hook to hook it out, or the dura, inspect the dura, there is no adhesion, then you can plug it out in a block. A lot of these cases now, if there are more than one level, I do UBE. It's also a very effective way in doing ossified thoracic OLF. Very similar principle, just drill the bone lamina off the flavum until you see pinkish epidural tissue, and then subsequently thin out the OLF by drilling and remove them as a block. Okay, after this we'll be finishing. I know my time is up. So overall, let's see whether I can fast forward this. Oh no, cannot. But anyway, remove them as this picture shows, as a block. And this is the post-op. With that, thank you very much. I hope we can little more and discuss this in detail. Thank you very much.
Next, we will have Professor Max Wu. He's an associate professor and department chair